So I'm Lindsay Browning. I'm the host for today, and I'm from the National Association of Medicaid Directors and have been your host once before, so really excited to be here. So next slide. So this group continues to grow. Last week, there were over 350 people on this call. So a fantastic network of individuals. As I joked at the beginning of the call, we're all going to be best friends by the end of this process. But folks who are really committed in leading this work of strengthening the crisis system and preparing for 988. Next slide. The Crisis Now website, want to remind you all to go check it out as a resource. All of the information from this learning community, the resources are available up there, and they continue to upgrade that landing page to make the content readily accessible. As you can see here, some of the recent Crisis Jam highlights are up there. You can listen to recordings from the calls, etc. So check that out, tell your friends, and use that resource. Next slide. So last week, we added a new feature to these calls, which is doing a word cloud around some of the work that folks are doing to sort of see where everybody's minds are at. And we asked last week, sort of what's your top priority for 2022 with crisis? And really three themes came up: equity, funding, and staffing. I think it's not surprising that equity came up as a top one, because we know that strengthening the crisis system is really a huge opportunity to improve equity and mental health access and services across the country. And similarly, funding and staffing are two of the main operational challenges we know that we're all collectively grappling with as a community in order to execute on that vision of equity, of building this system. Next slide. Our quote for the week comes from Patrick Kennedy, who, as you all may know, is coming to this call on January 26th to be the featured presentation. But the quote from Patrick is this: "It's time to shed antiquated prejudices and make a bold statement that mental health is not a moral failing or a crime. Let's take action now to right the wrongs of our past through a reimagined crisis system that benefits everyone." And again, I think that speaks to the word cloud and the focus that we have, the shared focus around equity. So with that, I'm going to turn it over to our featured presentation for today and not waste any time. John Palmeiri is here to share the first of, I think, a three-part series to talk about operational readiness for 988 and crisis. And I think you all know John well, but he is the acting director of 988 and behavioral health crisis at SAMHSA. So John, take it away.
Thanks, Lindsay. Really appreciate the opportunity to be here and to speak with all of you. You can go to the next slide, please. So one of the things that I think is really important to sort of emphasize at the start of this is really how SAMHSA recognizes that partnership is really the key to delivering on the opportunity for transformation that 988 presents to us. And we really see 988 legislation and the rollout and the implementation as really the catalyst and cornerstone for the broader crisis transformation. And none of this can really happen within the federal government alone. And so we really recognize and appreciate the passion, energy, expertise of partners on this call and beyond this call to really move toward that vision that we all have for transformation. So I'm going to spend a few minutes today talking in the first part about some activities that we have been organizing at the federal level within SAMHSA, really focused in on 988 readiness and implementation. And then I think that we're scheduled to come back maybe in early March to deliver on a follow-up where we'll spend a little bit more time on some of the other areas of our work plan. But first, to start, really just, and I know we've communicated these goals before, but really just wanted to emphasize that we have been really squarely focused on a couple of key goals this year. One is strengthening and enhancing the National Suicide Prevention Lifeline. And then the second goal is really the broader one that really is about that transformative opportunity to strengthen the broader crisis care continuum. And across these goals, there have been four pillars or categories of activity that we've been primarily engaged in. The first one is really recognizing the importance and the value of the federal government in planning and convening, helping to coordinate, bringing important partners together, supporting activities where possible through various funding mechanisms, and really asserting that leadership and policy direction to make sure that we're driving those goals of strengthening the lifeline and the broader crisis continuum. The second pillar of activity has been very much focused in on the operational specifics and readiness of the Lifeline network, really making sure that the Lifeline has the resources necessary to address all contacts, providing universal access, making sure that there's a standard high quality experience, and that we're always looking at service delivery through a lens of being culturally sensitive and equitable when we're providing those services. The third pillar focused in on messaging and public awareness, really doing a lot of planning around partner engagement and educating partners around 988 messaging, and really understanding that there is a significant need for broader public awareness about the life-saving services available by a 988. And then the last pillar is focused on the foundation or the building blocks really for that comprehensive crisis continuum. So making sure that there are building blocks in place to ensure that there's a robust and responsive crisis system that's coordinated and that's enduring and that is really built on continuous improvement as we move forward. And I'm going to spend much of my talk today focused on the first couple of pillars of activity here. We'll touch a little bit on 3 and 4, but again, planning to have more discussion in our subsequent presentation in March. And then, as I think was noted in the chat, there's going to be some opportunity here for some Q&A at the end of my talk. Next slide, please. So within each of those pillars of activity, we have outlined some strategic objectives that we think are important to achieve the goals that we're aiming for. And so here you can see a layout of those objectives as aligned with each individual pillar. I'm not going to cover each of these in detail today, but in bold, you'll see some particular call outs here that I'm going to spend a little bit more time talking about as we move forward. I think you can go to the next slide. So in pillar 1, which really again is about the federal leadership, convening, coordination, and funding, there's some activities here that most of you are already aware of, but really important to emphasize some recent accomplishments that we're happy to be able to deliver on, and those include the reports to Congress and the appropriations report on 988. So we've had lots of conversations over months, many months, unfortunately, about where the status of those reports, and we're very pleased to report that the 988 appropriations report is actually published on our website, and that the reports to Congress on resources and on training and access have been delivered to the Hill as requested. And so I know we've received a lot of inquiries as to whether or not we at SAMHSA can publish those other reports to Congress, but that really ultimately is a congressional decision in terms of the release of that information. We certainly can answer questions about it, and maybe there'll be questions in the call today, but for the purposes of our kind of authority, we're not able to, without direction, release those publicly. There's also been a significant, really unprecedented investment of funding to help the transition of the Lifeline to 988. So that has included, as most of you are aware, $177 million to strengthen, strengthen and expand Lifeline network operations and infrastructure. And then also, and I'll talk just a little bit more about the $105 million that's being directed to states and territories to build up local crisis capacity. And associated with that $105 million is the Notice of Funding Opportunity, which was released in December and is due back to SAMHSA at the end of January. And again, we'll talk, I think there's a dedicated slide to talk a little bit more about that. Next slide, please. So one of the things that I thought it was important, and this is something that is flagged in some of the language in the reports that we've submitted, is really to emphasize what some of the guiding principles are behind the goals and the activities and the objectives that we've sort of identified within SAMHSA as important with respect to 988 and broader crisis implementation. And so I'm just going to go through these fairly quickly, but really understanding that these are really underlying principles that really drive all of the decisions we make in terms of policy, coordination, grant opportunities, and so on. So really, number one is really to emphasize that 988 is really intended to be built upon the existing infrastructure that was noted in particular in the Hotline Designation Act, that 988 is directed to the National Suicide Prevention Lifeline. We really feel like that connection is critical. The Lifeline has been in existence for over 15 years, and there's been lots of evaluation work demonstrating the effectiveness of the Lifeline. And so we really feel that it's really critical that we build upon things that we know are working and that we invest more resources and energy into the capacity to make sure that it's really having the reach and the impact that we need. The second principle is that the experience for the users or the individuals in crisis should be seamless and should be consistently high quality. There really should be essentially a no wrong door approach for individuals in crisis, so that they, wherever they happen to access services, that they're directed to the resources and the supports that they need. And they shouldn't have to try to figure out the complexities of navigating a system that's fragmented and disjointed. We really are stressing the importance of ensuring that services are available to all in need. We really see, as I said at the beginning, that their partnerships are critical, and that includes multi-sector partnerships with federal, state entities, nonprofits, private sector partners as well. We really think that really is going to, in the long run, be the most sustainable and the most meaningful in terms of a system that works in the long run. We really feel that the integration of behavioral health services is critical into one transformed behavioral health crisis system. So that includes across the continuum of care, but it also includes sort of more diagnostic or clinical integration, so that individuals with mental health needs and substance use concerns ultimately are able to be served equally and effectively within a crisis system. Again, really ensuring that we have consistency across our standards, to really making sure that the system is funded adequately. And as I mentioned earlier, the federal government has made some additional investments, but really recognizing that there's going to need to be multiple streams of funding to support crisis services. And then also finally looking at opportunities for continuous improvement, making sure that we have data, identification of metrics, looking at the evidence base to inform practice guidance, and making sure that we have measurements that we can then look at that drive ongoing learning and ongoing improvement in the system. Next slide, please. So one of the other updates that I wanted to flag in this Pillar 1 activity related to coordination is some work that SAMHSA and Nashville have been engaged in with a number of other planning partners who are listed here, and many of whom are on the call, and their ongoing commitment is very much appreciated. So SAMHSA and Nashville have engaged in a co-sponsorship agreement, which is really intended to harness the energy of all of these partners, really to inform effective 988 implementation. So a lot of the work that's being engaged through this co-sponsorship currently is looking at readiness for 988 implementation across a number of key audiences, to ultimately inform a roadmap and to make sure that the audiences have the operational tools, supports, guidance that they need to prepare for 988 implementation, both in the near term and the long term. And really hoping that we can use this opportunity in terms of understanding readiness and the work that we're doing with SAMHSA to really build this integrated roadmap for 988 implementation, making sure that roadmap reflects feedback and incorporation from partners through this co-sponsorship agreement. And one of the things that I'll mention here is that the agreement includes the readiness work that we're doing now, leading to the development of specific tools and products that are going to inform guidance, and ultimately arriving at a national convening, which actually I shouldn't say ultimately, because that's going to happen fairly soon, because like everything, we're on a fairly accelerated timeline. So that work of the co-sponsorship group is really moving along very quickly toward a convening that's going to happen in the February to March timeframe, so that we can get sort of a fuller collection of partners at the table, really having a conversation about next steps, direction, ongoing learning, and ways to align on that vision and enthusiasm for crisis implementation. Next slide, please. You can move on. Thanks. With respect to Pillar 2 and the operational readiness of the system, obviously there's a lot of work happening here with SAMHSA and with Vibrant, who is the administrator of the Lifeline, around making sure. I think you might have skipped over, or maybe I'm going too slowly. Maybe this is a subtle way of telling me that I should go faster. But anyway, so there's a lot of work in Pillar 2 around the operational readiness of the system, and making sure, again, that we have the resources necessary to address contacts. So the previous slide basically had kind of milestones and a timeline related to that work around monitoring network effectiveness, really looking at key performance indicators around response rates, and time to response, making sure that there's some standardization there. We talked a little bit about the recent funding opportunities that are going out, understanding that this is a mammoth undertaking by Vibrant and SAMHSA in partnership with Vibrant, and that there's obviously a need to scale up lots of staff, both to support the infrastructure around Lifeline, but also to support the contact response, both with respect to the subcontracts that will be going out to answer chats, texts, backup calls, and then also really recognizing that there's a huge need to build up staffing at those centers, and that given the workforce challenges, we recognize that that's going to be a challenge, but something that we're really working and thinking outside the box to really try to deliver on all the different, leverage all the opportunities we have around workforce development. Next slide, please. I already talked about the notice of funding opportunity for states and territories. So in the interest of time, I'm just going to go on to the next slide. Here under Pillar 3, I know I mentioned I'll reference Pillars 3 and 4 fairly briefly, but just so there's an understanding that there is a whole pillar of activity focused on communications and messaging. We really see the overarching goal as really aligning a communication strategy and materials in support of the vision for 988, so that there's clear messaging and public awareness, and that these efforts reach both partners and the public in ways that are effective, equitable, and timely. We have some objectives underneath that larger goal, one of which involves developing partnerships that really can support meaningful communication, support for 988 implementation. The second one is really working with those partners to build coordinated, purposeful communication content and activities in advance of 988. And then the third objective, obviously, which is very critical, is really making sure that Americans know about the life-saving services available to them via 988. And again, making sure that we're looking at that particular objective through an equity lens, and particularly thinking about the perspective of individuals and populations at high risk for suicide, to make sure that the messaging that's designed really has the impact. Next slide, please. With respect to the second objective under communications, the first and second objectives really under communications and partnership. Kate, who's our communications lead on the 988 team, who's been on these calls, is our SAMHSA lead in the messaging task force with a number of partners that are listed here. So you can see that there's a lot of partnership engagement around messaging and communication, and that will be leading to more specific content and guidance through Partner Toolkit and other products that are being developed currently and will be launched a little bit later this spring. And there'll be more information about that in our subsequent briefing. Next slide, please. And I think this is the last slide before we move on to questions, is really to signal some direction around Pillar 4 activity, which really, again, is that building block foundational aspect of the crisis continuum. So that does include ongoing direction for collaboration and partnership. That includes within the federal government in terms of scanning points of intersection among other departments and agencies in the federal government that are engaged in crisis work, and there are many. And then also obviously continuing to collaborate and partner with external partners around ongoing learning opportunities, continuing to share the knowledge base around what practices are recommended, what are best practices, what does the evidence tell us. I don't want to get ahead of the data corner that's being introduced into this meeting, but I think that's going to be a key activity that's really aligned with looking at the evidence and really continuing to build our knowledge base around crisis services, promoting sustainable funding. That has been something obviously that we've been very focused in on. And the next slide, we'll kind of get to that a little bit, including the convening that we're doing with CMS this week, identifying lots of challenges and also some opportunities here with workforce recruitment, really, again, trying to think outside the box in terms of pipeline, apprenticeship programming, other opportunities to build workforce. And then again, really looking at that data element to make sure that we're driving the system toward ongoing and continuous improvement. Next slide, please. And this, I think, truly is the last slide, which again is just highlighting that objective that's really more focused in on financing. Again, really recognizing that aside from the $282 million that I mentioned that has gone out this year, I mean, there's been lots of investment in funding services that do have intersection with crisis activity. Most obviously, the mental health block grant crisis set aside, but that does also include CCBHCs as another mechanism for funding crisis services. You can see here the work that CMS has done around the state planning grants and the recent letter that supports mobile crisis FMAP increases. I think Thiessen talked about his the TTI grants with Nashville in the meeting yesterday. And then we'll continue to have a couple of learnings this week, today and tomorrow, to sort of wrap up the SAMHSA CMS national convening on financing options. So again, just some examples of some of the mapping that we've been doing across these objectives around crisis activities. And I'm going to stop there. I know I've probably gone a little bit over, so I apologize for that. A lot to talk about. As I said, we'll be coming back in early March, I think, to kind of do a deeper dive into some of these later pillar activities.
John, thank you so much. A lot of great information about what you guys have going on and how you're thinking about some of this. We've got a lot of questions in the chat. I'll try to get to a few of them, and some of them I know Richard has been answering in the background as well. But the first question that someone raised and I heard echoed in the chat is wondering kind of what specific activities you all have going on at SAMHSA related to 988 and equity. And sort of ensuring the cultural responsiveness of services of the call line. So any thoughts on that, and similarly sort of how lived experience is being incorporated into the planning work?
Yeah, those are great questions. So I'll give a couple of examples that I think can respond to some of that question. So one is around training. So certainly with respect to our recommendations on training for crisis center staff, really making sure that there's sensitivity and awareness of the needs of populations at high risk for suicide, specific training on LGBTQ plus youth, communities of color, a lot, really recommendations regarding sort of the recognition of how law enforcement response has disproportionately impacted certain communities, and making sure that all of those elements are key, incorporated into training in terms of how crisis workers respond to individuals in crisis. We are also building on that to do a bit of a deeper dive into really understanding what the needs are of some of those populations, both with respect to communications, which I did reference very briefly, which is some of the work that Kate and some of the partners are engaged in around formative research, but also really informing system design. So really understanding that for communities of color, for other populations that might be at high risk, really understanding like how they interact with service supports, how they seek help, who are influencers in those populations, and how we sort of learn from them in terms of the ways that they want to, learn from them in terms of the ways that they're going to be able to access care that's most impactful. And then making sure that we're, both messaging to that, but also more importantly, designing the system that really meets those needs. And then finally, I would say with our co-sponsorship work, we are actively engaged with organizations and individuals who are representing communities with lived experience and making sure that there's a lived experience voice in how we design, how we understand readiness for 988 implementation, and then how we sort of provide guidance around operational supports and tools that really reflects the voice of individuals and communities with lived experience. Again, really wanting to make sure that the system is designed from the perspective of the person in crisis, and wanting to make sure that is reflected throughout all the work that we do.
Great. I'm going to try to squeeze in two more questions, and then I know we got to move on. But first, the other question I wanted to ask, someone in the chat raised, is SAMHSA setting any standards or planning to set standards for how 988 operates when jurisdictions are operating the system? Is that something you guys have in the works?
I mean, there are standards in terms of lifeline operations. So I'm not sure if that's what the question is getting at, but we already do have, a set of standards, obviously, in terms of call response or contact response, assessment for imminent risk, response to inquiries around, suicidal ideation. I mean, there are a set of standards, protocols that already exist, and there definitely will continue to be enhancements of those standards as we move forward. Some of that will be informed by specific population needs or evidence or additional training opportunities, but there absolutely will continue to be standards expected for the performance of the 988 Lifeline centers in terms of the way that they respond to individuals in crisis. I know it's kind of a very broad answer, but I guess the short answer is yes.
Yeah, and I would just add that that when you look at the notice of funding opportunity for states, there are certainly requirements there. Those are different than national standards. The National Suicide Lifeline Improvement Act, which passed the House and is under consideration in the Senate, explicitly would call on the Department of Health and Human Services to develop standards in a wide array of areas.
Got it. Okay, good to know that that's floating out there, that policy is being considered. One last question, John, and this may be something to revisit next time, but someone was asking about sort of what the measures of success are for the 988 rollout. What are the big things you guys are thinking about that you'll be measuring, looking at to see if the rollout is successful?
Yeah, that's a great question. And I mean, there are some short-term things that we're looking at, obviously, with respect to response capacity. So that includes response rates, both at the national level. What are the response rates locally? What is the time to response? What are the abandonment rates? So there are some really concrete kind of key performance indicators that we're looking really immediately at with respect to contact response. But then there's longer term work as well. And as part of our data and evaluation plan that's looking at, are we reducing law enforcement response to crisis? Are we ultimately reducing suicides? Are we reducing emergency department boarding? I mean, I think there's a lot, and there's a lot in between. So I would say absolutely, we're building out a very thorough and comprehensive data and evaluation plan. Some of them are really focused in immediately on the performance of the Lifeline system, but then there are lots of broader implications as well that are just as important to really understand, are we actually having the impact that we're intending to?
Great. And lots of other questions in the chat. I know the team is taking those down, and we'll either put them on the agenda for a future call or make sure we get some information around to folks in other ways. But we do need to move on because we've got some other agenda items. So go ahead and go to the next slide. So next, we're going to move to our crisis talk this week. So I'm going to hand it over to Stephanie Hepburn. Stephanie?
So yeah, this week I interviewed Paul Galdes. He's the deputy CEO at RI International. And he pointed out in the article in our interview that building out just some of the core elements in SAMHSA's national guidelines for behavioral health crisis care will result in continued system challenges. And I think states and communities are navigating, trying to figure out where to start, where to invest funds initially, and how to build out. So, Paul, if you're on the call, if you could talk a little bit about how this could result in continued marginalization, especially for those who are most marginalized, if all three areas are not built out properly.
Sure. Thanks, Stephanie. I think it's, it's driven by this vision of when SAMHSA leadership said, look, we need to develop some national guidelines as we work to advance crisis care. And those of you that have tracked and seen the document, it was published, it'll be 2 years ago next month. And it was designed with a couple of thoughts in mind. Anita Everett might be the first one to say, look, we need someone to call, someone to come to you, and a place to go. And in fact, John Draper kind of echoed this serve anyone, anywhere, anytime approach. And the task wasn't to improve access to care, but it was to fundamentally shift so people did have access to care in all scenarios. And so what you're talking about, Stephanie, is look, I think 988, we have to get this right. We have to shift from 911, and we get this opportunity. We see the success of the National Suicide Prevention Lifeline, and their efforts really got us to a place in which we resolve a majority of those calls by phone. And when they do that, they can connect them with outpatient supports, and it's successful. And those that need mobile response, you get the mobile teams out there. And I love the energy that's going into building mobile response, the enhanced federal match that's going to help make that a reality, I hope, across the nation. And then we have these crisis receiving centers, a place to go. And I think, again, SAMHSA's leadership was really important here, because what they said is, look, we have a model that we've seen. The emergency response system for physical health challenges is working right now for the most part. We can call 911. They can dispatch EMS, and an ambulance will be out there to serve the person where they are. And if someone has acute physical health challenges, whether that is EMS bringing them in or they go in themselves, they can go to an emergency department and everyone can get access to care. That's what we need to have for mental health and substance use. And we were really cognizant. So when you get to this last part, Stephanie, of what you talked about, those with the biggest challenges, those that need or would really benefit from this receiving center, the emergency department, if you don't have it, the current response we get in our nation is a justice system law enforcement response. Law enforcement goes out, they potentially take someone to an emergency department, and far too often we are seeing individuals get involved in the justice system when in fact these are mental health substance use crises. So if you go by the numbers, that's a small percentage compared to the overall group that's having crisis, but is a percentage that is going to cycle in and out of our justice system if we don't tackle that receiving center piece as well.
And you mentioned also, I don't, if you could just quickly touch on it, and people can go to the article to read more, but you talked about funding and who should be building out the crisis facilities and what that might look like. Could you talk just a little bit about the funding aspect?
Yeah, so the national guidelines that SAMHSA published, again, 2 years ago, and they are available on the website, do a few things. One is they start clearly defining 3 core elements of a crisis system that we just described: this crisis call center, the mobile crisis response, and the receiving center and stabilization piece for individuals in crisis. And so as you get definitions, you get minimum standards for those things, and they're bulleted. In fact, you can get each service probably covered in 1 page of that document. And then you see what are the best practices, what does that look like for individuals. It's then followed by how you potentially fund these systems, how you code for these services in a really straightforward way. Again, we're talking about a couple of more pages that give some pretty direct guidance. And SAMHSA's leadership really said we need to have a practical way in which we can help communities advance this. And the foresight's fantastic, because we've been working on this for 2 years now. And again, the go live for 988 is 6 months away. We're remarkably close. And I think we now have a bit of a roadmap to get there. We have some tools, and the tools that are also included in there include the crisis resource need calculator, the Crisis Receiving Center Staffing or Workforce Demand Calculator. So you get some insight into those resources that are sitting on NASBID's www.crisisnow.com website. And then you'll see some great examples of work Jamie Snyder, Dana Hearn, and the Arizona Medicaid team have led around service delivery. Fantastic work that Debbie Atkins and the team at Georgia have advanced as well. So there's really good examples to reach out and see what could be done.
Thank you, Paul.
Great, and I really appreciate the system perspective, right? That's how we tend to think about things in Medicaid, and really helpful to approach this work in that way. So let's move on to the trivia hot seat. We do a lot of work here in this group, but we also like to have fun, right? So this is today's trivia question, and the person in the hot seat today is Vic Armstrong, who's the Chief Health Equity Officer at North Carolina's Department of Health and Human Services. So Vic, the question for you today is, in 1958, this city's Suicide Prevention Center launched the nation's first free and 24/7 crisis hotline. So we're going to open up a poll to the audience to help you out, and then you can choose to accept or reject their suggestion for you. So we'll give that about 10 seconds or so. So you got to vote fast, folks. And I'll admit I got this one wrong, so.
And you pick which one?
I'm not going to tell you. No hints from the moderator. All right, we can go ahead and close out the poll. And Vic, here's what the audience says. You can choose to accept or reject. So they're saying LA and Dee Dee Hirsch.
I am going to assume that we have a smart audience, and I'm going to go with the audience, and I will pick C.
All right, can we go to the next slide and reveal the answer? Yeah, so C is the answer. The pioneering work of Dr. Edwin Schneidman in Los Angeles was replicated by cities across the nation. So Fulton County started their crisis hotline in 1966, sort of replicating what was done in LA. So I guessed wrong in the pre-meeting for this. I was thinking it was Atlanta. So really interesting to hear that LA is the place where this started. So thank you.
Do I get a prize? No?
I don't know. The admiration of this group, right?
Thank you.
Thanks, Vic. All right, we'll move on back to the serious work here. So John, I'm going to turn it back to you for the SAMHSA update.
Thank you. I'm actually going to turn it over to Richard and others on the team if there's anything else that you wanted to add. I think you probably heard enough from me today. So.
Yeah, I'll just add a couple of things that for looking at questions that have come up in the chat. The really important issue of geolocation was mentioned, and that we think that will be crucial to 988 911 interactions. There really is not an update around that, but we continue to communicate to the FCC about that. We're hopeful we might hear more from them in the near future, and I believe that they have been invited to come to this group to talk about that, if I understand correctly, which I think would be great. Also, we are in the process of coordinating with various tech companies regarding facilitating texting to 988. That is so that's ongoing work, obviously on a rapid time scale, because those companies are required by the FCC to make 988 texting to 988 operational by the same July timeframe. There was also a question about coordination with 911. We do have multiple streams of efforts that are currently ongoing. We have ongoing meetings, including one this morning with the Office of Emergency Medical Services and the Department of Transportation. The language of the notice of funding opportunity, the 105 million for states, included language about having a plan within the state around 988, 911 coordination. SAMHSA has provided a modest amount of funding to Vibrant to support a community of practice on 988 and 911. And SAMHSA, as well as Vibrant, are also participating in a working group that the National Emergency Number Association has established regarding 988 and 911 collaboration, and how that can be established, how that can be enhanced with development of a protocol. So there's a lot of different streams of efforts. We're looking into, there's also the development of resources through the co-sponsorship agreement on this topic that's ongoing and will be incorporated as part of the national convening that John spoke about. So this is just a hugely important area where we have multiple streams of effort going on. But we are open to all feedback because it's a different world and different landscape from our typical mental health or behavioral health world. And we're trying our best to learn it, as much about it, and to talk to people with expertise in it so that we can do the best possible job moving forward. We know about there's a good number of our current Lifeline centers who have existing memorandums of understanding with 911 PSAPs, but a lot depend on informal relationships. And of course, relationships can shift. So a lot of important work being done and that needs to be done in this area. So thanks.
John and Richard, just wanted to flag one other comment in the chat around CMS coordination and broader funding. Does either of you want to just speak to that briefly?
Yeah, thanks. Oh, go ahead, Richard. Sorry.
Okay, I was just going to say, I think John mentioned a couple of those things. There's a conference going on this week on that, but there is the 85% enhanced FMAP, the federal Medicaid match that is available currently that can be used for mobile crisis. There is the set aside for the mental health block grant that can be used for either for mobile crisis, for crisis receiving stabilization, or for regional or state crisis hotlines. So there are a number of different funding streams. There was also CMS guidance specifically around mobile crisis that came out relatively recently, and that I think has been distributed, but we can make sure it gets to you. I think that guidance was just released in the last couple of weeks, if I'm not mistaken.
Yeah, that's correct. And if anyone wants to nerd out about Medicaid claiming, check it out. I know I gave it a good read. It's pretty interesting. John, anything else? Richard?
I mean, I would just add to, Richard said just that we are obviously engaged with CMS in an ongoing way and looking at other opportunities to provide some more guidance to the field on, sustainable funding strategies. So, hopefully more to come in that area. So.
All right, great. It sounds like SAMHSA is hiring, so check out the slide. Next slide. And here's the SAMHSA 988 team, in case folks need a refresher. Great. Well, let's shift to the Nashville update. So Brian, I'll hand it over to you.
Thank you, Lindsay, and thank you for moderating. Thank you to SAMHSA for their leadership. John, James, Richard, thank you very much. Also want to thank Paul Galdis for his leadership in helping to develop and writing the national guidelines for behavioral health crisis care. It's a document that all the states are using, whether they're trying to advise the executive branch, their legislature, or working with stakeholders. That document has been very helpful. At Nashville, we have regular calls with states. Last week, we had a call with Arizona, And Jamie Snyder, the director there, was talking about some information that I thought would be important to share with this group. So it's my pleasure to introduce Jamie Snyder, the director of the Arizona Healthcare Cost Containment. She is over Medicaid and behavioral health. Jamie, please go ahead.
Thanks so much, Brian, and thanks for allowing us a few moments to talk about some of the work that we're doing with our American Rescue Plan Act dollars. I think as it relates to the call today, just wanted to convey that we have really made a concerted effort to direct some of that funding, whether it's coming through the home and community-based services provision or the additional SABG and MHBG block grant dollars to support both our crisis services delivery system as well as our overarching behavioral health system here in Arizona. On the HCBS side of things, if we go to the next slide, there are a couple of different ways that we're using the funding. I'm sorry, to the next slide, please. Really around strengthening the workforce and modernizing the HCBS system. And in regard to strengthening the workforce, one of the ways that we're really directing dollars under that opportunity with the expansion of HCBS to include rehabilitative services is around offering advanced training to direct support professionals, including BHTs and BHPPs, behavioral health paraprofessionals, who are interested in serving more complex populations, individuals who have a serious mental illness and have intellectual disabilities, for instance. We also are directing some of the dollars toward a public awareness effort around caregiving, paraprofessional caregiving and recruitment efforts, and specifically targeting peer support services and family support services, and targeting those that are currently served by our system, and really enlightening the broader public about the merit, the value, and the fulfillment of caregiving pathways. So again, using some of those ARPA dollars to support our behavioral health delivery system more broadly. We also have a provider stabilization initiative, no surprise there, given some of the workforce challenges that we're facing really across the care continuum, whether it's in kind of traditional HCBS services or in the behavioral health arena. So really directing a pretty significant portion of our HCBS funding to a directed payment for direct support providers. And I'm going to turn it over. We also have some work around modernizing our HCBS system and using technology to foster independence among those we serve. But I'm going to turn it over to my colleague, Dana Flannery, who's going to talk a little bit more about how we're directing some of our block grant dollars to crisis-related activities.
Hi, everyone. I'm Dana Flannery, and so I'll just talk through a little bit. I know we're limited on time. Next slide. So I'll focus here on crisis because that's what we're here for. And so looking at all of the mental health block grant opportunities that we have written to and are awaiting approval for. And so kind of going back to what Paul talked about with those best practices, you want to stack your system against those best practices and see where you still have room to grow. And so in Arizona, that electronic crisis services locator will be very big for us. And then wrap around for children with an SED designation. We do also have some room to grow with our 23-hour crisis stabilization units for children with SED, and then short-term behavioral health residential for settings for children with SED. And then if you can see, again, limited on time, but some of these other efforts for the children's, for the adults living with serious mental illness, for our first episode psychosis, all of that is going to help build that continuum. So crisis prevention and then post-vention after the crisis, what continuum do you have to move people towards? And on the next slide, couple of efforts from our SABG ARPA opportunities, looking at primary prevention, women's services, and general support services. I did go ahead and drop the link in the chat for our American Rescue Plan efforts, as well as our grants efforts as large. So again, ARPA is just one piece of this. And so really looking at all of the other grant opportunities that we have to help strengthen our crisis system. And so some of those are underway as well. Thanks.
Hello, sir.
Hey, I have some disappointing news.
Oh God, what's up?
Thank you very much, and I'll turn it back to Lindsay. Thank you.
Awesome. And Jordan, if you could mute
Hey,
yourself,
our
that would be
press
great.
off is at 11:30, is it?
It's at, well, I don't know what your time is. It's at 2, I believe. 2
Sorry,
p.m. my
just
time,
wanted
so
to get
11
that
your time.
muted. Perfect. Okay, Jamie and Dana, quick question for you both before we move on. You mentioned that you're using some of the home and community-based services funding to sort of build the workforce capacity around individuals who have dual diagnosis, IDDD. Are you connecting some of that work to the crisis stabilization work as well? Because that's another place where I think we've seen challenges in serving that unique population. So just curious if you have any follow-up thoughts on that.
Absolutely, Lindsay. I think one of the other areas of opportunity for us in terms of building out our existing DCW or DSP training program is really providing additional training and education around our crisis services delivery system. So really, you know, all professionals and paraprofessionals throughout the delivery system are aware of the resources that are available, know how to connect members to the crisis service delivery system, and have an idea of sort of various entry points into that system based on the individual's level of need. So yeah, that's absolutely something that we're looking at in terms of bolstering our existing training and education program.
That's great. And for folks who aren't familiar with the HCBS money, this is another investment that has gone to Medicaid. It's time limited, and in some states, states are able to use that to address behavioral health as well. So not all states, depending on how your program is structured, but some states. So definitely look into that and get familiar with what's happening there in your state if you haven't already. All right, let's move on. I think next we're going to go to Sarah at Guide Consulting to give an update, federal update.
Thanks, Lindsay. And if we can move to the next slide, I will give my quick update here. All right, on that first row on the reconciliation package, also known as Build Back Better, not a whole lot of updates in the past couple of weeks. The earliest we think we might have an update is potentially at the end of this month, but it's seeming that the State of the Union, which is scheduled for March 1st, might be a forcing event to see if we can get that back moving in the Senate. So hopefully we'll have updates sometime in February, early March to see if this package can move forward as it is or in some sort of form. On the second row, the current continuing resolution is up on February 18th. It's unclear if they will be able to come to an agreement in some sort of omnibus or longer term spending for the rest of the fiscal year or not. If not, it would be likely another continuing resolution, but it seems that negotiations are ongoing between House and Senate appropriations leadership on that front. And then third, just a quick reminder, the Senate Finance Committee is going to be having a hearing on youth mental health and the crisis among youth that is currently happening and being reported on more and more. I will drop the link to that press announcement from the Senate Finance Committee in the chat, but that is scheduled for the 26th of this month and includes at least the Surgeon General, potentially a second panel as well. They're still kind of formulating that, it seems, in the Senate. So that's it for me.
All right, thanks so much, Sarah. And I know we don't have any updates from AFSP, so we'll move on to the next update, which is the state update. So Hannah, I'm going to turn it over to you, Hannah Fernami, to give us a quick update, and then Laura and Steph, if you want to jump in as well. So Hannah, you might be on mute if you are speaking up. And we don't hear you, so I don't know, Hannah or Steph, do you want to jump in?
Hi, Lindsay. This is Stephanie. I think actually Laura wanted to kick things off for the state update.
Apologies, Laura, go for it.
Hey, no worries. I think as long as we're sharing the information, it doesn't matter who says it. I did want to just let folks know that as states are reconvening for their 22 session, by my count, we have 33 states that either opened last week or are opening this week, plus DC, Puerto Rico, USVI, Guam, and some of the other territories. Also wanted to share for folks that there have been some hearings. So in Washington State, there's a hearing tomorrow on legislation related to suicide prevention and posting the lifeline number on bridges. There was also a question in the chat around 911 and police engagement. And I think it could be helpful for us in the future. I know Washington State is also working on some legislation related to police and use of force. So that could, that legislation doesn't specifically call out 988, but could be helpful for us to get, just an on the ground picture. I'll also note that Kansas is having a 988 focused meeting today at 1:30 their time. We'll also kind of turn it over to Stephanie to talk about some of the developments in New York and Florida.
Great. Sorry. Thanks, Laura. Just put in the chat a link to where you can view that Kansas hearing that will be happening at 1:30 Central Time. Yes, so I know we haven't had a state update for a couple weeks. So just to recap for folks, while hopefully people were on holiday in late December, there's an update in New York. So their 988 legislation, S6194B, was actually signed by the governor. And this legislation was changed quite a bit before it was signed into law. There was chapter amendments to this that changed a lot of the text, essentially replaced a lot of what was in the bill. And what is left is a requirement for the State Office of Mental Health and the Office of Addiction Services to issue a report to the governor and the legislature about what resources the state needs to provide to implement 988. And that report is due by January 21st. And so since that legislation importantly didn't include any direct funding for 988, advocates in the state are really now turning their attention to Governor Hochul's budget, which will be due in a few weeks. And it's very important to make as much noise about the governor including sustainable 988 funding streams in her proposal. So anyone on the line who is in New York or from a New York organization, I'm going to put in the chat an ongoing letter writing campaign from NAMI New York State. Encourage you to activate your advocates on that and spread that around if you could, please. Some other quick updates on some other states. California, Governor Newsom's budget came out on Monday. There is some good news there. 7.5 million is proposed for FY 2022 and 6 million for FY 23 for the Office of Emergency Services to implement 988. That's mostly focused on the 988 crisis hotline centers and the coordination of 988 and 911. There's also 1.4 billion proposed for mobile crisis teams as a Medi-Cal benefit. A couple other quick updates in Florida. They had SB 478 passed out of committee yesterday. That is a 988 study bill, also focused on financing recommendations within that bill. And very quickly, Illinois SB 2945 also passed out of committee yesterday. This establishes the 988 Trust Fund. That's a provision within the 988 state model bill that protects 988 related revenue. And I know we are quickly running out of time, so I will wrap up. Thank you, Lindsay.
Awesome, thank you. Well, we will fly through these next couple of slides, just some quick reminders because I want to land as close to on time as we can. But there's a new stats card up for Virginia. And of course, the other ones are up there as well, Washington State, Nevada, etc. So for our last piece here, I just wanted to turn it over to Dr. Matthew Goldman to talk about the National Survey of Mobile Crisis Teams. Matthew, quick update.
Yes, thanks so much, Lindsay. I know you only have 1 minute, so just really excited that today we are launching the first ever National Survey of Mobile Crisis Teams in the United States. This is a partnership that's been a long time coming, working closely with Vibrant, SAMHSA, Nashville, and others, as well as my colleague, Preston Looper, to launch this survey. So the link is here. I put the link in the chat. You'll be seeing a lot more about this as we try to get every single mobile crisis co-responder, any kind of field-based mental health crisis response team in the country to respond to this survey by the end of February. So thanks so much.
Fantastic, and we look forward to seeing the results. So let's move to the coming soon slide. Just a reminder about what's coming next on these calls. Next week, we're going to talk about 911 and 988 integration. So that connects a lot with what you all have been talking about in the chat. Patrick Kennedy is coming January 26th. And then a whole great lineup here for the next couple of months. So it was really a pleasure to see you all today, to talk with you, and looking forward to continuing the work as we move into these last couple of months before 988 goes live. So thank you all so much. I hope you have the great rest of your day, and see you next week, same time, same place.